Welcome, GVSN Prasad. How are you?
Hi Vishnu, how are you?
Fine, fine.
I'm fine here. Yeah. Let's enjoy the talk by Sonal.
Yeah.
Yeah.
You are
Nice.
working where now, nowadays?
I am in a private medical college near Vijayawada, Pinnamneni Siddhartha Medical Education Research Foundation, run by Siddhartha Academy. This academy runs 18 institutions, including engineering, arts, law, science, all this medical and dental college. Only one medical and one dental college is under the academy.
Yeah.
So I'm there since 2016. So as professor and sole person in the department.
Okay.
Yeah.
So before that, where were you?
I was, actually 97 to 99, I did my MCH at Osmania, Nilofer Hospital, Institute of Child Health. Then 99 to 2006, I worked as assistant professor in Nilofer Hospital itself as faculty. But due to government, there was no chance of promotion. Actually, 7 years was enough to become a professor in state service according to NMC guidelines that time.
Yeah.
But there was no associate professors, adequate number of associate professor posts created. We had vacant professor posts, 10 out of 10, 7 were vacant. And we all were eligible. But out of 22 assistant professors, only 2 associate professor posts were there. So there was a bottleneck. So I had to resign due to financial this thing, because the salaries were very low at that time, 2006 time. So very low. So I had to resign, come back to Vijayawada, join NRI Medical College. That time it was established by a group of NRIs. And it had a good reputation till 2010-11. So it attracted all the best talent of Telugu doctors from various central institutes. They all joined and it reached a peak. And unfortunately, as you know, among Indians, they have a group rivalry. They split into 2 groups and damage their own institution. And ultimately, it is landed into the hands of an administrator. High Court is interfered, and then our CM, Honorable CM, is planning to usurp the institution. You understand, no? So we are unfortunate or fortunate to have such a chief minister of our state who's selling off the entire state, landing us in a debt trap. That is the reason. And 2006 to 2011, I was in NRI Medical College. That is near Guntur and Vijayawada in between. And 2011, because of financial issues, I left and joined Narketpalli, that is in Telangana, Kamneni Medical College. I worked there 2012 to 2016, 4.5 years. Then once the department, they started in Pinnamneni Siddhartha, I joined there. So all these places I worked in pediatric surgery. I started the departments, worked there, set up the departments. Then due to various reasons, I had to come back. Yeah. This time you are having some get-together, you said in update in April,
March 31st.
Okay, I will book my date. Last time I couldn't do it. My father was not well, so he expired in May 16th. So 87 years old, he had non-alcoholic liver disease with cirrhosis. Unfortunately, he died. 87 years old. So that time I got in touch with Sonal and used to talk to him. And that way I came familiar with him, Sonal.
Was there any planning for a transplant?
No, I asked Sonal. He said the oldest person transplanted was 75 years, something like that in India. So he was in end-stage liver disease, no varicose bleed till then, but hepatic encephalopathy he went into. Following what happened was he had a spontaneous D8 vertebral compression fracture. So almost he had severe pain, bedridden. That was the preceding cause. So osteoporosis, then spontaneous fracture of D8, he was bedridden because of pain for almost 2-3 months. He had to use that all those medicines for pain. Ultimately, physiotherapy thought he will come out, but again he went into hepatic encephalopathy. So for 1 week, almost last April and May, he was there. May he had 1 week he was semi-conscious at home only. So, and then I consulted a medical gastroenterologist here. They said not much of use giving the hospital. Okay, Vishnu, sorry I held you up. You may have to talk to other guests also.
Yeah. Welcome, Sonal.
Hi, Vishnu. Thank you so much for the invite.
Yeah.
Hi, Sonal.
Hi, how are you?
Fine, Sonal. Waiting for your talk. Pediatric liver transplants. I just want to inform you the child, unfortunately expired 1.5 months back. Hepatoblastoma involving the entire 3 segments of liver. They couldn't afford financially, so went to Vizag, whereas probably Tata Fundamental Research, they have set up a cancer hospital. By that time, it was already metastasized. So he died at home before, they could afford any transplant program. Unfortunate, but I saw the attendant in the hospital when he came. When I inquired, this message was conveyed to me. So this is the reality. This is the reality.
Now, despite there are so many challenges at every level. No? One is that the initial counseling, whether it's been proper or not. Finance obviously is the biggest challenge.
I told them, see, you can try with it, but probably they were told some 10 lakhs, something like that. So probably it was difficult for them. I don't know what exactly were the other reasons, but that was the indication which they told me.
Only 5 lakhs actually, because we don't. With the evaluation, we would offer it to 5 lakhs. But today I'll just probably talk about it a little bit more detail, more than the surgical part, which I think a lot of people know. I'm talking to talk about the structure.
This thing has to be conveyed because pediatric population is a bit different. Most of them cannot afford unless the government support is there. Correct. The government should approach the government for funding these programs in different states, so that no child will lose his opportunity to get the transplant if you can provide, because the specialists are available now. My time there were hardly any liver transplant surgeons in most of the centers. So now in Hyderabad also we have a lot of liver transplant surgeons also. Absolutely. That message should be conveyed to the government as well as the society.
Yeah, no, I agree with you.
Yeah, that's what. Thank you, Sonal. I am waiting to hear your lecture in a few minutes' time.
Sure.
Okay,
Well,
nice.
We usually start the lecture at 12:02, so please wait at 12:02.
Yeah.
Now we have Shaktivel. Shaktivel is recently joined our institute.
Okay.
He has done his fellowship in liver transplant from King's College.
Very good.
And he has done some 3 months fellowship also in pediatric liver transplant from Japan.
Very good.
Good afternoon, sir. Good afternoon, sir.
Hi.
Is it Ravindra from Duke's University, or I'm unable to recognize? Good morning, sir. Good morning.
Hey, Vishnu, how are you? Sorry, it's past. It's
1:30
a.m. here, so I just got up to join. Thanks for inviting. Hey, Sonal, how are you?
Well, thank you. Thank you so much for joining from, it's an unearthly hour for you. So sorry about that.
Yeah, I know. No, Vishnu had sent a message, and actually I'm on call this weekend, but I thought, I'll join you just to see how it's always a pleasure to join anything, from connected to our alma mater. And Vishnu, thanks for inviting. Yeah, so I happen to be free, not in the operating room, so it's good to be here.
Ravindra Garu, can you hear me? Then Dr. Prasad, GVSN Prasad, pediatric surgeon.
Hey, how are you? Good to see you, man.
Fine, sir. Fine, sir. Seeing you after a long time.
Yeah.
Baunara.
Nice to see you.
Baunara.
How are you? So good to
fine,
see
sir. Fine, sir. So nice of you to see you.
Where are you now with GVSN?
Vijayawada, sir. Vijayawada. I'm working in a private medical college as professor of pediatric surgery. Pinamneni
I see.
Siddhartha Medical College, Pinamneni Siddhartha Institute of Medical Science Research Foundation, run by Siddhartha Academy.
Oh, I see.
Vijayawada.
Oh, very nice. Very nice. Oh,
Yeah.
okay.
So I'm settled in Vijayawada since 2006.
I see. Oh, very good. Congrats.
Thank you, sir. Near the
very
end,
good.
almost.
So, Sonal, are you in the operating room? You see, you're in full scrubs.
Yeah, actually, our oncology team today, for some reason, they posted a Whipples with the vascular resection on Sunday. So I think they probably didn't get room, during the week. So
I
I was
see.
just around. I think that they'll probably get away without the resection, so I'm free. So.
Oh, good. Yeah, nice. You could join in. Yeah, fantastic. Eager to listen to your talk. Glad you're doing such
No,
great work.
absolutely. I must warn you that this is going to be quite different from a regular talk in terms of. I'll obviously talk about indications and such, but what I really wanted to talk about was a funding mechanism that we have developed to help children get access to transplant, actually, which is we've been running for the last 6-7 years. So, it's not just a surgical talk. So. Focus will be a little bit more on equity and access as opposed to technique as well. So technique, there's a little bit, but a little bit more the second part, actually. So.
Oh, thank you. That's really crucial what you've done, in terms of ensuring access to a lot of underprivileged folks in India. That's really creditable. Congrats, Sonal. Just eagerly looking forward to your talk.
Thank you so much. This is exciting. Yeah, obviously, starting access in places like Jipmer is a huge step, because a lot of the population that needs transplant actually comes to Jipmer or institution like Jipmer. So that's a huge, next step that we need to develop actually in the country. So.
Right.
Yeah, people will be joining slowly. So usually we start the lecture at 12 too. So it is time to start, I think. Let me first introduce Dr. Sonal before he commences the lecture. Dr. Sonal did his MS, I think MBBS also from JIPMA. And he was actually 1 year junior to me during MS. And after that, his MS, he joined as a senior resident at All India Institute in Surgical Oncology. And after completion of his senior residency, he went to Leeds for doing fellowship in liver transplant. From there, he went to Canada for doing ASPS fellowship. Then he came back and set up a liver transplant initially in Global Hospital. But from there, he moved to Oster Medicity, where he really made it big, and he established the biggest liver transplant center in Karnataka. So welcome, Sonal, and he is going to talk today about one of the difficult areas of liver transplant as a pediatric liver transplantation. Very few centers in India specialize in this, and Dr. Sonal's center is one, and his center's name is also put up in the textbooks of liver transplantation. So welcome, Sonal, and you can start your transplant. People will be joining slowly. So nearly 45 people will join usually. Right? You can go ahead.
Thank you, Dr. Vishnu. Thank you so much for the opportunity. Obviously, it's such a pleasure to be able to talk among colleagues and peers as well as seniors. And I see at least 3 people who've been involved in my training, apart from Dr. Vishnu. I see Dr. Prasad and Dr. Ravindra, who are all our seniors who we learned from. We sort of cut our teeth on surgery with sort of seniors, and certainly what they have taught us is probably more than what you could learn in any books. I owe everything that has transpired so far to the solid foundation that we got in Jipmer, and it's a real pleasure to talk about about what we do here today. And I must warn you, as I was sort of sharing a little earlier, that this talk is not a pure clinical talk, because from the beginning I've been, I think what troubles all of us is not just about what we do in terms of the technique, which we obviously get good at as we go further along, and as long as we work in good teams and are able to provide support. But how are people going to be able to access the skills and the life-saving surgeries that we do? these are not obviously intuitive questions in India because we don't have universal healthcare. We don't have a mechanism by which everybody can access this. So a large part of my talk is going to be focused on access to transplant as well. I'm going to just share my screen now, and is my screen visible?
Yeah, it's visible.
Okay, so essentially, the talk is focused on affordable pediatric liver transplantation. These are my current appointments. I do not have any conflicts of interest for giving this current talk. The first thing to sort of understand is that obviously we do know that there is a pediatric liver disease burden in India, but the exact numbers are actually a bit of a mystery, because when we talk about the baseline for what we use the burden of disease in India, which was published in 2005, there was actually no mention of cirrhosis. When we look at WHO data, approximately 3% of the total deaths that occur in India occur because of liver disease. Currently, when we sort of all put it all together, liver and GI cancers are among the highest increasing cancers. They're increasing about 20% year on year in urban India. And soon the incidence of liver cancer is likely to parallel the incidence of head and neck cancer in India. This is something that I discovered yesterday. The data for India is a little bit sparse on pediatric liver disease. We know that there is an incidence of approximately 6 to 8 per 10,000 live births for EHB or biliary atresia. And this incidence seems to be more in the east of India, but this is mostly anecdotal data. Unfortunately, we do not have any clear numbers. Broadly speaking, based on extrapolation from data from adult literature, we think that approximately 2,000 children require transplants in India every year. And this number is obviously likely to be off by a factor of several fold. There are several different things to consider when children with liver disease present. The first thing, obviously, is the age of presentation. Early on in the first 1 year of life, EHB or extrahepatic biliary atresia is the commonest cause of liver failure. Most of these children present with cholestasis. Broadly speaking, jaundice after life for the first 2 to 3 weeks is normal. If there is a persistent jaundice with clay-curdled stools, these children should be investigated. The investigation is typically takes the form of an ultrasound scan or a HIDA scan or a biopsy in some cases. And these patients sometimes do turn out to have either neonatal hepatitis or biliary atresia. Biliary atresia, which is picked up early on, is amenable to treatment with a Kasai operation. Biliary atresia that is neglected beyond 70 to 80 days typically has underlying liver disease and would require a transplantation. Unfortunately, in the absence of a screening program, most of the children present to us with delayed biliary atresia. Most BAs are picked up at a time that is not amenable for Kasai procedure, and they end up either going for a delayed Kasai, which is not as useful, or an upfront transplant. The other things that actually present in the first year of life are involved metabolism, galactosemia, tyrosinemia, and PFIX. We'll talk a little bit more about that because this is an interesting entity which we are seeing more and more of, or perhaps recognizing more and more of, which presents within the first 1 or 2 years of life. Between the ages of 1 and 5 years of life, we see a large number of other problems. Certain inborns or metabolism manifest after the first year of life, usually after weaning. GSTs, tyrosinemia, autoimmune hepatitis, PFIX can present. Indian childhood cirrhosis is something that we see very little of anymore. In fact, we haven't seen a case in almost a decade. And this is one thing that has disappeared from the textbook. It is a little mysterious. There are a lot of theories, but currently we do not see as much of Indian childhood cirrhosis as before. I would probably include pediatric liver tumors in this group as well between the age of 1 and 5. Some of the transplants that we do are done for pediatric hepatoblastoma or pediatric HCC within this duration. Between 5 and 10 year duration, we end up dealing with a slightly different patient age group. We see children manifesting with Wilson's disease or later presenting PFIX. PFIX 3 and PFIX 7 are things that normally present a little bit later. course, we can have Budd-Chiari developing at any of these times as well. And between 10 and 18 years of age, we see a little bit more of a pattern that is familiar to those of us who treat adult liver disease. We do see Wilson's manifest a little bit later in teenage, and this is when we have liver and sometimes neuro-Wilson's as well, autoimmune hepatitis. We see some children with hepatitis B cirrhosis as well, and broadly speaking, a lot of the manifestations here are more recognizable to the adult population. So how do these children normally present? Normally, these children can present in a variation of different ways. Broadly speaking, the earliest presentations that we see in, say, neonatal children are cholestatic jaundice. Cholestatic jaundice that includes children who develop aside jaundice, they have clay-colored stools, some of them have pruritus, and they have repeated attacks of cholangitic illnesses which will require admission. These children normally present with a very, very high INR, which is usually linked to vitamin K deficiency. The INR is correctable to a large part with vitamin K administration. When we look at their LFT patterns, they present with direct bilirubemia, elevated alk-phos, and gamma-GT. So one of the key things to look at here is whether the presentation is a low gamma-GT or a high gamma-GT presentation. If the gamma-GT is very, very low, then we must think about things like progressive familial intrahepatic cholestasis as opposed to biliary atresia, which is more of an obstructive. The other part is hepatocellular damage, which is seen in cases like autoimmune or metabolic cases. These are linked present with transaminitis, derangement in albumin, and they can present with ascites with encephalopathy. Of course, a very dramatic presentation is acute liver failure, which would also fall within this particular domain. Now, an ALF that is presenting in a child needs to be treated with caution. We need to investigate certain things which would not be amenable to treatment. So if we have a small child that presents with ALF, one of the first things to think about is to see whether the triglyceride in the ferritin is elevated beyond a particular point. So if you have hemophagocytic syndrome or HLH, then that may be something that is not amenable to treatment with the liver transplant. Equally, mitochondrial derangements can present with acute liver failure, and these are things that present profound lactic acidosis. So certainly, when you have ALF presenting in a small child, there needs to be an investigation to be done not just for the etiology, but also to look for causes that may not respond well to liver transplantation. Again, a more standard way of presenting with cirrhosis, portal hypertension. This can happen in very small children with diabetes, splenomegaly, or in some cases with GI as well. There is a small proportion of children who present after the age of 1 with depending on the degree of acuteness or acuity, they can present with profoundly elevated AST/ALT, a large tender liver ascites, and interestingly, the synthetic function in these children is usually preserved. GSD is something that we all know about. These children present the classical Buddha feces, which we've all heard about and seen as well. So pediatric liver transplant is about 10% of the liver transplants that are done across the world. The population is actually quite distinct, as I've presented in the first 2-3 slides. Not only is the population very different from adult liver transplant, but even within different age groups of children, between neonates, infants, between 1 to 5 years, preschool, as well as adolescents, there is a very big difference in etiology and presentation. And of course, the difference is not just in the primary diagnosis, it's also in the comorbidities, especially because for infants, you're looking at, multi-system involvement, for example. And in older children nowadays, we do see more diseases that we normally associate with adults, for example, diabetes or obesity. The kind of graft that you would consider for these children, a small child might require a monosegment, or, but a larger teen might require a full graft. Post-transplant complications and long-term complications. So the first question that patients normally ask me when they walk into the clinic is, will this transplant work? We are transplanting a child, how long will this child be alive? So, one of the sort of most rewarding things about doing pediatric transplant is that the survival rates are quite good. we can expect a more than 90% survival at 1 year, and even more rewarding is that the survival persists up to 15 to 20 years. Most of the late deaths are because of complications of immunosuppression, and some people do develop, biliary cholangiopathy as a form of antibody-mediated long-term rejection. This data is likely to change, and now, in fact, as you can see in the last, we expect these children not just to live full adult lives, but to become grandparents as well. So the Indian picture that we talked about, essentially, we think that about 2,000 children might need liver transplant, and this number is probably a very conservative number. The number of Indian children who are transplanted right now is probably close to 100. The number of total transplant done according to the Indian liver transplant registry in the last 4 years is approximately 450 for children. The mortality without liver transplant is almost 90%. Mortality, the survival after liver transplant is 90%. So clearly the risk benefit is also very, very well defined in these children. As discussed, children do very well after transplant. This was one of the first children transplanted in the world in 1970 by Dr. Thomas Tazel. The first picture, she's a bit yellow. 6 months later, she's cleared of jaundice. And this picture was taken in 2016, 46 years after her transplantation. Clearly, they can do that. And this is something that we've seen in our own practice, where we had transplanted young children between 7 to 8 years early on in our practice, where the mom donated with acute liver failure. 6 months later, the jaundice has cleared up. And later on, you can see these children are now, young men and women, and they're college going now.
LH17.
Sorry?
LH17 1601.
Not
Resident. Part time. रहता हूँ. Yes.
Hi, Funny.
मेरा own house है भाई. वाइफ रहती है तो उसके लिए.
Again,
LH17 1601.
Yeah. So to reiterate, basically we have discussed all the indications. The large majority of the children that we see below the age of 1 are biliary atresia, and this forms the biggest component of the transplant that we have done. Again, as we have discussed, complications can be because of failed portal enterostomies, they can be because of hepatocellular failure, they can be because of portal hypertensive complications, but also, quite importantly, in children, growth failure is a very important indication. If we have a child that is, in the 10th to the 5th centile of their height and weight, then transplantation is a valid option, because if children are not growing or developing properly, then that actually is a significant problem. So what are the goals of liver transplant evaluation? Firstly is to define the indications for the transplant. Why are we doing a transplant? Is it for liver hepatocellular failure, portal hypertension? Are we doing it because of growth failure? What is the best time to do the transplant? What are the specialized treatments that may be needed, for example, for an AVN compatible transplant? Is there any special treatment or immunoadsorption that is needed for the transplant? Make a care plan that involves the preoperative, perioperative, and postoperative care, and this has to be extended to the long term as well. When we evaluate these children, we are assessing their cardiopulmonary resolve. The second part is the most important, optimizing the nutrition. So we see a lot of the small children, with biliary atresia, which are usually about 5 kilos, and we should do our very, very best to work with a dietitian to make sure that their weight increases as much as possible. The goals that we had learned in our fellowship were to aim for a weight of more than 10 kilos. Practically, I have never managed to successfully do that because most of these children are too far gone nutritionally to actually build up. But certainly, if we are able to get the weight to about 5.5 to 6 kilos, we are normally quite happy with that. Manage the complications of liver disease, bleeding, ascites, etc., so that we optimize the child. Make sure that the child gets normal childhood immunizations except the live vaccines, as well as aggressively treat infections. Now, pediatric liver transplant is possible because we are now much more well-versed in using segments of the liver, as laid out by Conard et al., as opposed to the whole liver. Now, we know that there are 8 segments of the liver, each of which has a separate arterial supply, portal venous supply, venous drainage, as well as a biliary drainage. So it is possible to use, either the whole liver or segments of the liver that include one or two or more segments. So of course you can have a whole liver. You can transplant a left lobe, which is segment 2, 3, and 4. You can transplant a left lateral lobe, which is segment 2 and 3. And for very, very small children, you can do a reduced left lateral or a monosegment transplant, segment 2 or segment 3 reduction, based on the fitting of the child. And then that allows you to transplant children that are very, very small. The goal here is to get at least 2% of the child's body weight as hepatocellular mass and not exceed 4.5 to 5%. And of course, there are numerous schools of thoughts here. There are a lot of people who believe that the total body weight or the total hepatocellular GRWR is not as relevant. But certainly in our hands, we found that when the graft to recipient weight ratio is more than 4%, we do, complications do happen. And more importantly is that the domain of the abdomen is too small to incorporate a very, very large liver. A lot of what we do in terms of planning involves, segmentation using specialized software, which allows us to calculate the volumes based on venous anatomy and portal venous anatomy. That allows us to precisely calculate how much each segment is. We have supplemented this recently by using 3D printed assisted treatment planning, where we use the CD essentially to create a 3D model of the liver, which is printed in transparent silicone. This actually gives a very precise rendering, and we have used it for 2 pediatric cases. The difference in volume was just about 10 ml between what was projected in the 3D model and what actually we got. And very importantly, it is a very good learning tool for people who are starting careers in surgery, because we can actually define transaction planes very, very cleanly and without putting a patient at risk. Again, as discussed, we can either look at deceased donor transplant, where split liver transplants are an option. In our country, most of the transplants we done for children are living donor transplants. They're either full left lobe transplants, left lateral segment transplants, or reduced or monosegment transplants. For infants, in our situation, it is usually a reduced monosegment transplant that is usually used primarily because most of our children come with very small body weight. The bigger challenge that we face here is a lot of children with biliary atresia come with atretic portal veins, where the portal veins are very, very small, and the portal veins need to be reconstructed. This is actually achieved either by using a patching the anterior wall of the portal vein to increase the diameter of the portal vein, or secondly is to use an interposition graft between the SMPV junction and the donor liver. Both of these things are things that we use normally. In very, very extreme situations where the portal vein is not accessible, a renal portal can be considered as well. The arteries are usually very small in these situations. We prefer microvascular arterial anastomosis because occasionally you do get 2 arteries, a segment 4 artery and a segment 2 and 3 artery. So doing 2 small arterial reconstructions is best done by microvascular surgeons who are trained in this. In terms of biliary reconstruction, we prefer doing room-wide hepatic jejunectomy in these situations because the risks of leak and late stricture are significantly high. Absent IVC, where you could see that the SMPV junction was intact, but the portal vein was atretic, and then the IVC was gone, and we basically solved this problem by reconstructing the IVC, doing a graft anastomosis here between the left vein to the IVC graft, and then using an iliac interposition graft between the SMV and the donor portal vein. This child is now alive and well 7 years after its transplant. The complications for pediatric liver transplant are also slightly different. We anticipate problems at different points. The first, again, reiterating basically the importance of having working with a really good pediatric critical care team. For very small infants, having an excellent pediatric critical care team is very essential. Short-term complications, vascular complications such as hepatic arterial thrombosis are relatively common in children because the size of the vessels is smaller. venous problems are also significantly commoner because of relatively lower flows and the more chances of the graft kinking because of a smaller domain. Rejection and infection are things that can happen in adults as well as children. And long term, again, these things change as time goes by. There can be complications of immunosuppression, chronic rejection, PTLD, which we see much less of now. As children approach teenage, a big problem of non-compliance is seen, and we do have children stopping taking medication and then coming back with rejection very late after their transplants once they reach teenage years. Long-term complications obviously carries its own risks, where we have risks of malignancies such as cutaneous malignancies. So I think that's basically what I wanted to talk about, the indications as well as some of the surgical techniques. Obviously, liver transplantation is rewarding and useful. I mean, these were a pair of twins that shared everything, and they shared a bottle of rat oil poison that they found under the sink. Both of them presented with acute liver failure, and we were probably one of the few centers that actually transplanted identical twins. Mother was a donor for one, and the aunt was a donor for the other. Both are doing well 3 years after their transplant. This was another child with hepatoblastoma, whose father, who you see in the picture, is an Uber driver in Bangalore. And this child was transplanted, is about 9 years post-transplant, doing well after transplant. The reason I showed you these is because these are obviously people of very modest means. But the biggest problem that we face when we work in India is addressing cost. Now, how do we offer something that costs transplantation, which is demands a lot of skill, a lot of material, is an expensive process? How do we make sure it is accessible to people? So when we actually look at overall data from India, the costs of a transplant in India are significantly lower than the costs across the world. So we compare the data to the UK or Canada or the United States. In India, you can do adult liver transplant for about $30,000 and a pediatric liver transplant for approximately $15,000. And why the cost so low in India? Primarily because there's been a fair amount of innovation, especially in the LD&T space, that has come out of India. So one is ABO incompatible liver transplant from Dr. Soin's team, the reduction of using immunoglobulin. These are all things that were pioneered in India by Indian papers, using split livers and dominant livers, which are all the surgical things that were developed in Professor Rela, and decreasing the use of blood and blood products, which has been something that we have some expertise in. The big, again, one of the policy questions that one can ask is that is transplant something that India can afford? Because obviously transplant is expensive. It strains a lot of the additional resources that are available, wards, operating theaters, blood banks, and intensive care units. And whenever we allocate resources to a particular thing, then it competes with resources which are essential for other things like healthcare, sanitation, immunization, and child health. As India gets, as our GDP increases, as more attention is paid to health, and as facilities develop, I think that it's probably extremely important to offer transplantation to everybody. Transplant can become accessible to people when it's offered in institutions like JIPMER. And certainly, I think that with a lot of the welcome changes coming in our healthcare spending, that is something that will happen as a matter of course. What drives cost in transplantation? Obviously, we have consumables, the infrastructure in the hospital costs, profit, which is an important thing for private hospitals, professional costs of paying the surgical teams as well as the critical care teams, and more importantly is the variability. Because, for example, a transplant itself may not cost very much, but if there is an infection, if there is multiple relaparotomies for, say, an arterial thrombosis, those things can increase the cost substantially. So we had started something called the Affordable Transplant Initiative a few years ago in 2016. This was linked to certain things that we, some of our own experiences, because some of the children that came to us could not afford transplant. So we decided to create a program where children with liver failure should have access to liver transplant regardless of their family's economic status. So basically what we thought was that a transplant that costs 25 lakhs should be offered at a 90% subsidy. Over the last part of my talk, I'm going to talk about how exactly we've done that. Basically, we've done that by creating a funding model, which involves the government or the patient, involves crowdfunding, and corporate social responsibility. So essentially, the idea is that the patient pays a certain amount, which is matched to some degree by crowdfunding. And once these two things are met, then the balance is funded by corporate social responsibility payments. So when we talk about CSR, there is a new law in India which has been, there has been a long tradition of corporates actually funding beneficial things. So we know from the Tata Group, for example. But this was ratified law in law by 2013. Broadly speaking, the summary is that all businesses above a certain size are required to pay 2% of their profits into projects that are linked to corporate social responsibility things. Obviously, healthcare is one of those topics. So healthcare, CSR, the law seeks to address the problems of society in a cost-effective manner. And if it is used well, then it can generate up to $4 billion. Clearly, this is something that is still in application. That is something that is not a lot of dollars are not using. What we have done is interest a few corporates in pediatric liver transplantation, and they actually fund and audit our program. So broadly speaking, how does this work? We look at a total budget where the family is paying 2.5 lakhs, which is then matched by societal funding, corporate sponsorship, as well as subsidized hospital costs. So that this flywheel will show you how we are able to decrease the burden to the family itself. How does social media work? Of course, social media is the double-edged sword of our times. You can either love it or hate it, but you cannot ignore it. And certainly, Facebook is sort of front and center there. And what we know is that Indians really, really like Facebook, because India has the highest number of Facebook users in the world. Currently, approximately 300 million or 30 crore Indians are actually on Facebook. So, but this obviously, apart from the challenges that it faces, also creates some interesting opportunities for us. Just for example, to give you a thought experiment, if the total number of Indians on Facebook, just 29 crores, who all presumably have access to the internet and mobile phones, if all of them paid 220 rupees per year, that is approximately 12 rupees per month, then the entire expenditure on Ayushman Bharat in 2021, which was 6,400, could actually be paid for. So there are some times when India's population actually comes in useful, and this is certainly one of those times. If we actually had a mechanism of tapping social media engagement of Indians across the internet, then actually there is funding healthcare itself, or anything of means would actually not be difficult. And certainly that was helpful for our child, Tanmay, whose father drives an Uber. So as you can see, this was a platform that we used, Milap. And when this child came up for a transplant, we had to raise about 16 lakhs for his transplant, which we could raise in about 4 days' time. So using this kind of mechanism, we have funded more than 200 transplants. We've raised about 11.2 crores, and we currently have about an 88% survival in this group. So not only have we shown that it is possible to do transplants for this cost, we have shown that you can do it without affecting the survival and the long-term outcome of these children. And this actually was taken up by IIM Ahmedabad as a case study, where the crowdfunding aspect of what we developed was written up as a case study of helping patients by facilitating philanthropy. And this is currently available both on IIM Ahmedabad as well as on the Harvard Business Review. So certainly pediatric liver transplant has been a very, very fulfilling journey for us. This is an event that we organized with some of the children who actually had a transplant. And certainly the reward is hard to measure just in dollars and cents. And it's sometimes measured in pictures such as this one. Thank you so much for your attention. I'll end here. I'm happy to take any questions.
Oh, that was an excellent lecture by Dr. Sonal. So before I open this for question and answer, I just would like to ask a few questions, Sonal. Yes. So far, how many pediatric liver transplant you have done at your center, and in the center you were there before also?
Yeah, so essentially we have, since this program has started, we have done approximately 208 pediatric liver transplants. We currently do about 30, last year, between January and December, we've done 32 liver transplants as a center out of a total number of 210. This includes the entire Aster group, that we operate in. So our pediatric liver transplant numbers are, as a percentage, are slightly higher than what is reported in literature, mainly because of our affordable initiative. So a lot of children do seek us out separately as well. So normally it's about 10%. Ours come in at approximately 20%.
And what percentage are for chronic biliary stasis? What percentage biliary atresia?
So most of the infants that we transplant are actually for biliary atresia. About 70% of the infants that we transplant are for biliary atresia. For transplant for slightly older children, the commonest indication that we see is neglected Wilson's disease. And Wilson's disease presenting as acute liver failure, which is actually ACLF, because they have cirrhosis, is a fairly common indication.
Yeah. And what is the percentage of patients with acute liver failure, pediatric patients?
Pediatric acute liver failure in our situation is quite seasonal. We see every year we would probably transplant about 4 or 5, which are during the monsoon time, which is usually linked to either hepatitis A or hepatitis E or a seronegative hepatitic illness. Okay. The numbers are actually still relatively small as compared to this thing. But we do see for every one that we transplant, we see about 4 or 5 that do not make it to a transplant as well because of challenges and delays in that.
Yeah, and I request others to unmute themselves and ask question. I think Professor Ravindra can ask first, followed by Shaktivel, and then others can start asking.
Hey, Sonal, again, just to recap, it's excellent presentation. Thanks for what you're doing in India, and it's really appreciate all that you've done. My relationship with Sonal goes back to Jipmar. We were there together for, Sonal was just a few years behind. And we crossed paths again in Leeds, where we were, at the time in early 2000s. And then I followed him closely. And then we met a few times when he was training in Edmonton. Really, I think, Sonal, you're a trailblazer in many ways. And really, what you've achieved is really commendable. Taking the lead and getting it done in Bangalore, establishing a very successful transplant unit with a focus on pediatrics, and just this initiative, the Affordable Liver Transplant Initiative, where you have raised over 11 crores and transplanted over 200 children. I think that is the crowning glory of what you've achieved. That's really, I think that's the cherry on the pudding, as we say. So really fantastic work. Couple of just to give perspective from where I work in the US, just as in comparison, you said probably 1,000 liver transplants are required in children to meet the needs of Indian, current the liver disease burden in India. In the US, it's about 600, somewhere in the range of 600 to 700 liver transplants are done in kids in less than 18-year-old per year, out of which majority are disease donor. The living donor component is only about, somewhere in the range of 12 to 15%. So majority are still living donor. Of course, the disease donor component here is 90%, which is actually reverse of what is in India. Recently, I was in Medanta, and even Dr. Soyen's unit, out of 300 plus liver transplants they do, barely 12 of them last year or year before were from disease donors. So that's a complete, it's two opposite sides of the spectrum, so to speak. And I really would like the advantages of disease donor, at least in our center. For example, in our center, we did 16 pediatric livers last year, out of which 4 or 5 were living donor and rest were disease donor. Most of the disease donors here are possible because the children get prioritized. They get extra points so that any splittable graft, which most of the time is less than defined here as really less than 40 years of age, preferably less than 30 years of age, where the left lateral segment is amenable to being split. Those our current policy has been, especially at our center with the perfusion technology, most of the livers, these livers are actually placed on the normothermic machine perfusion, shipped to the center, and then we split the liver at once it comes here in the morning. We don't even operate at night now. So this is split in the morning into the left lateral goes into a child, the entire remaining right lobe goes to an adult. So that is, I think that's where India can evolve with in the future. That is going to be the challenge, is really building up disease donor transplant. And that will be the challenge for Dr. Vishnu and others working in JIPMER, which has such an excellent facilities to actually push for living donor. Living donor is already well established. It is 90% of the transplant in India. But I think over the year, I really want disease donor to build up in India, because that's a huge resource in India which is not being utilized. So many people, and that could also reduce the costs. And that's where I would like to, I really want focus there, and would appreciate any comments from Sonal on that front.
I mean that's that certainly is a very valid point. And when we came back from North America, certainly that was our single focus, because that was what we knew. Deceased donor was, and there are huge advantages to having a deceased donor program. There were certain challenges that we faced initially. Firstly, was overall across India, even in the centers such as, or the states where there are strong deceased donor programs, like Karnataka has done 178 deceased donors this year. Telangana has done about 200. This year, for the first year, we'll cross 1,000 as a nation, actually, deceased donors. But most of the donors are actually not very well managed. So most of the donors are managed in small peripheral centers. They are not adequately resuscitated. Most of the grafts are actually of fairly poor quality. So paradoxically, our deceased donor survival is much lower as compared to our living donor survival, even when you look at the ILTR data. And so grafts that are actually good in terms of prima facie, they're coming from young donors, from RTAs with no comorbidity, essentially end up becoming marginal because of poor management. And again, the second thing is the logistics are often quite unfavorable. So in Karnataka, for example, a lot of donations are happening in tier 2 and tier 3 cities now. For example, Belgaum, Hubli, Mangalore. So there is a fair amount of not just poor management, also logistic support of travel involved. The pumps are not that commonly available to us. Organox was available briefly, but it is not available in India right now. So Hope is available, but again, it's quite costly. So currently, the pumps are not very widely used. We've just had about 50 deployments of the pump in the last 1 year, in India. So that's why even when you look at large centers, the amount of split work that happens is quite low. The largest data comes from Professor Rela's unit, where Srinivas Reddy, who's also our alumnus, had actually written it up. And most of the experience that we ourselves have also is with in situ splits. So where we have a donor in our center where we know that everything's as well optimized as we can, and we do it almost like a living donor. We do an in situ split, and then we use the graft. And those are actually the only cases where we've had success, because otherwise the results for ex situ splits have been quite bad across India. So it needs a little bit more of a sort of a holistic approach to improving the donor quality, access to maybe perfusion pumps, and the skills required for splitting. And the skills actually are available because of the expertise with live donor. But the other two things are things that are currently not that well standardized in India.
Thank you. Thanks.
Dr. Shaktivel, would you like to ask? Please unmute yourself.
Good afternoon, Sonal sir. It's very inspiring to listen to your talk and share your wonderful experiences. And thank you so much. And I really like your last slide. And I recently joined JIPMER after my transplant training. So my question is, it's not a technical question. As an advice to an early career transplant surgeon, what do you think are the tick boxes before one should think to venture into a pediatric transplant?
I mean, firstly, congratulations on coming back to JIPMER, and you're in a fantastic place. I certainly think that, compared to where we were and comparing it to the JIPMER of now, the opportunities available to yourselves are immense. I mean, not just for resources, but also for in terms of minimum collaboration and getting access to patients obviously were always there, but getting access to information networks, etc. In that is really possible. I think that first thing to do when setting up a program is to build a community and build a strong team. Obviously, the logistics of building teams in the public sector are very different from the private sector, but we would not get anywhere without our pediatric critical care, for example, because the technical performance of a transplant is one thing, but the critical care is immensely difficult, and it actually is a completely different ballgame. It's not something that we are probably as tuned to do. So make sure that the pediatricians that you're working with you, pediatric hepatologists and the pediatric critical care people are well versed in transplantation and learn to work in teams, because that's probably one place where we have much to learn from Kings, where you're trained, and the West as it were, teamwork. The second thing which will probably help a great deal is to probably engage in some sort of mentorship with centers that are doing a good volume. Because protocols obviously are available across the net as well as from your training centers, but there are a lot of centers that have individualized protocols based on Indian circumstances, availability of certain medications or things. So I think that twinning yourself with a mentoring center, like Professor Ella Center or our center, which are doing high volume transplant, are actually good. And by twinning, I do not mean only medical personnel. I also mean the nursing personnel, your physiotherapists, your dietitians, and who are going to be involved in the care of these patients. So if as part of the Liver Transplant Society of India, we have a center mentoring program as well, where one can approach, a high volume center, and we can actually create a model very similar to the TTS having a mentor-mentee program. We also have a center mentoring program which can be facilitated through the auspices of the Liver Transplant Society. So that could be certainly another model that would help you. But go out and make friends. You can't do anything alone.
Yes, sir. I'm looking forward to connect with you for all sorts of help for the program. Yes, sir. And the other question is, sir, you said about the crowdfunding for the pediatric transplants. So that's able to cover the surgical cost. How are you able to manage the long-term follow-up and the complications for a pediatric transplant when they come with infections and they come?
So that's a very, very good point. So essentially, we have a fairly strict screening for children when we take them on to for transplantation and support. We do not support children who are too poor to be able to afford anti-rejection medication. Currently, the cost of immunosuppression in India is very, very low. You could do immunosuppression costs currently at between 5,000 to 7,000 rupees a month. If we include the first 3 months where there's a lot of testing, it's usually about 15,000 rupees a month. So if somebody is not able to pay 5,000 to 7,000 rupees a month, then we do not typically engage them in the program. Equally, if someone's really affording, obviously they don't need to be in the program. So there certainly is a certain segment of patients who you can help. You cannot help really, really poor people because you're not doing them a service, if you're transplanting them if they're not able to take care of patients. So that one is patient selection. Second is having relationships with pharma companies who are usually happy to provide bulk immunosuppressors for a period of time at low cost. Like tacrolimus tablet, just to give you an example, it costs about 27 rupees a tablet from a good Indian brand. We can get tacrolimus at 11 rupees a tablet with the tacrolimus levels included. If we say that this particular patient will be taking medications for a 1 year time, So I think that those discussions can be had, and certain pharmas will be definitely amenable for that. The other two things that we have used in this situation are creating corpus with the crowdfunding mechanism. So, for example, crowdfunding is a bit variable. Some patients will collect 20 lakhs, some patients will collect 4 lakhs, right? So, if there is extra money collected, we take a special consent from the patients and the funding platform to use it in a similar fashion for somebody else. So, usually we will have a corpus of some amount of money, which is actually useful for managing complications. The last part, which we have currently started to do, is actually engaged with state governments directly. So because most governments now under the Ayushman Bharat or microinsurance schemes have some degree of funding available. Like to give you an example, Orissa has got something called the Biju Swasth Kalyan Yojana. It gives 5 lakhs for boy children and 10 lakhs for girl children. Okay. So what we have done is engage with the government of Orissa and tell them that please pay what you would normally pay. Okay. And then the rest of the money will be raised by crowdfunding and CSR. There is no burden on the government, there's no burden on the patient. That will match that. The big advantage of that is immunosuppression is then covered by the government. Okay. So we have signed an MOU with the government of Orissa about a year ago. Right? We're currently looking at MOUs directly with the government of Arunachal and Rajasthan with a similar model, where they pay whatever they have to pay under Ayushman Bharat, and we raise the rest of the money. So that allows us to engage, and particularly because children are not coming to, Aster and Apollo, they're coming to Jipmer, they're coming to, state medical colleges. So how do we make sure that access is available there? So the best way to do that is to work directly with governments. And that's what we started.
Yes.
So
Sir, I spent my last 3 months with Professor Kasahara. So he was really impressed with your work in pediatric transplant. He mentioned about you and Professor Srinivas Reddy. Just wanted to say that.
He's that's really, I mean, that's high praise. Thank you so much. I really appreciate it.
Thank you, sir.
Sonal, there is a national organ transplant program which supports the transplant by paying some 6,000 rupees per month for immunosuppression. Are you not making use of this?
Okay. So there are approximately 30 programs in the at the state and the region level as well as national level that are purported to support transplantation. Transplant actually is among the most heavily supported programs in the entire health program. Unfortunately, the process, again in India, the difference between creating a mechanism and the delivery of the mechanism is very, very poor. Okay. Like, for example, you have, just to give you an example, you talked about the NOTP. There is something called the Rashtriya Arogya Nidhi. Arogya Nidhi, again, Saktivel, this might be of interest to you, because the Rashtriya Arogya Nidhi will support transplant up to 15 lakhs if the transplant is done in a government institution. Okay. So there are certain inclusion and exclusion criteria, but those are exceedingly difficult to get a hold of. For example, there is a cost for ICU maintenance of a donor, 50,000 rupees per day for an ICU maintenance, which is actually laid out by the NOTP. So far in the last 9 years, not a single donor has got that. Okay, so unfortunately in our country, the challenge actually is in service delivery. We are very good at making laws. We're not so good at implementing them.
We have Madam Angeline, she is the Joint Director of SOTO, Pondicherry. I think she may be having some questions. Please, Madam, please, you can ask.
Am I audible?
Yes,
Hi, Sonal. Thank you so much. I knew Vishnu will snap me into this, so I got ready. As Dr. Sonal had said, we have just started our SOTO. We are trying to find our feet. We have not got salaries, let alone fight for donors now. We are working in the direction, putting up GOs, trying to chase the files. It's a lot of work. But I do understand from SOTO, from the ROTO point, Tamil Nadu has some systems in place because it has been there for a long time. And we do know that they are able to give the immunosuppression at a very subsidized rates and things like that. So there's nothing much I can tell you other than what is written in the NOTO website. We have not yet asked for immunosuppression and stuff like that. We do get mails from them and we are proceeding with placing our government orders. And Dr. Sonali, who's an expert, he has told that, yes, there is a big gap between what is written and for what ultimately, is able to happen.
No, but I mean, one thing that Vishnu, I would like to make a point to Dr. Anjali as well. One thing that keeps coming up in people's mind is the cost of immunosuppression. That really is not a problem in India anymore. So when I started training initially, tacrolimus used to cost 400 rupees per milligram. Currently, I can get it for 11 rupees per milligram. A government doctor will probably get it at 6 rupees per milligram. Okay, it's the cost is not a problem really, because it's at this point, most of the population, I would say, a lot of the population is able to afford the 3,000 or 4,000 rupees that we're talking about. And that's, I mean, even for the government, it's not a very big ask actually.
Question from other GVSN and Sauradeep and others. Please unmute yourself and ask.
Yeah, hi, Sonal. It's just a request from my side. Is it possible for Liver Transplant Society of India to register for ATG donations from income tax pays?
We are working on that, Dr. Prasad. Actually, it was set up as an agency only in 2018. And there's about a 3-year period before you can register for ATG. So this has been something that has been, discussed in the LTI executive. And we should be able to, start the application for that, because we are a not-for-profit. We should be able to do that.
Yeah, that's a well thought out idea, because we will be willing to pay and to an organization which is doing a lot of excellent work in this field. So as individual taxpayers.
Yeah, no, for sure. I think that it's under process for sure, and I mean it's something that that is currently we hope to be finish that over this coming year.
Keep up the good work, Sonal.
Thank you so much, Dr. Prasad. Thank you.
Any question from others? Anybody else would like to ask any questions? So I just wanted to ask one technical question, because when I was in Taiwan, I had seen Professor Cholang Chen in some cases where there is a portal vein problem because of some sort of inflammation or atresia, they used to stent it by opening the segment forward. Probably you might have seen their publication also from the Champion Memorial Hospital. They used to put 10 millimeter diameter stent, and they used to, as per their publication, it used to be patent for nearly 8 years or so. Such a sort of thing, have you ever tried or for a patient with biliary atresia?
Yeah, I mean, biliary atresia, we do face portal challenges every so often, because portal veins are very atretic, and even after patching, sometimes you cannot get adequate flow. I've never personally had to stent it, but the technique described by Dr. Chen and also most recently by Dr. Neerav Goyal in Delhi, which involves actually opening the vertical part of the portal vein, approaching it from the falciform, accessing the left vertical part of the left portal vein, and using that to access the portal vein beyond the anastomosis, is something that we have used. Occasionally, once you do an anastomosis, you end up with thrombus. You feel your anastomosis is good, then rather than redo the anastomosis, it's easier to just make a venotomy and trace it down from the falci into the vertical part of the left portal vein and pass a Fogarty from there. So that's something that we have done. We have accessed the root that is actually very close to the Rex recess as described in the Rex shunt, but we've never actually had to stent it.
Okay, thank you. So any more questions from anybody? Sauradeep would like to ask, or Devashish, would you like to ask? So before there's some message here, I think. Okay. So before I end the session, I would like to thank Professor Ravindra, who has taken pains to join us. He has encouraged us in many ways. He is one of the actually biggest contributor for our skills lab, which we have successfully established in our department. And it's actually, the moment he joins, we feel encouraged. I'm immensely grateful for it. And I would also like to thank Sonal, who readily accepted and came forward and gave a lecture, which is so beautiful and shown us the way how to go ahead with the transplant program. Thank you all. Anyone who would like to comment can comment still.
Congrats, Sonal, and good luck to Saktivel. Hope JIPMER can really make an impact in pediatric liver transplant and the in the academic sectors, teaching sector
Thank
in
you so
India.
much, sir.
Good luck. Good luck.
Thank you so much, sir. Thank you.
All right, pleasure joining, Vishnu, and
Thank
see
you.
you then. I get back to bed. Sorry.
Absolutely. Thank you so much for staying up, Dr. Ravindra. And thank you, Dr. Vishnu, for a very kind invitation. It's a pleasure to be here.
Okay. Thank you all. I'm going to end the session now. Thank you all.
Thank you.
Thank you.